mainly for the postgraduates, as Thiru told. Not only just for postgraduates, more from the exam point of view. In a practical aspect, if you completely do a spinal examination thoroughly, it will take 10 hours. So this is not that kind of screening in the OPD. It's mainly from the exam point of view. Even from the exam point of view, it is impossible to cover entirely the complete clinical examination in, let me say, 45 minutes, 1 hour talk. So I will be talking only about what most of you will know most of the things. That is a very known fact. And again, I'm not going to tell you anything more than what is already in the literature. So you would have read, you would have listened. Let's say it be a refresher for those who already know, and for those who do not know, maybe something will be gained. Now, just like what Dr. Thiru told you, basically, very, very rarely somebody fails in a spine examination. Almost 40 years, I can tell you, I don't remember of anybody having failed. Just what they do. Now, the question is why all of us are again afraid, mainly because our teaching, examination, everything is mostly in the hip cases and similar cases. That is one reason. Number two, spine examination can take little more time. That may be the factor. But on the whole, I can tell you that spine is easier because much less controversies in clinical examination. So with that, I will go into the thing. Now, whether it is spine or hip or knee or shoulder, what is important in your clinical examination is to be following a systematic approach. This I know is not the first time you would have heard. You would have heard from so many of your teachers, and you will be telling to others tomorrow. But this is very, very true. Particularly in an exam sitting, when you are tense, you tend to forget. So there, if you have followed always, and I always tell my postgraduates, from your postgraduate point of view, don't think that you have to follow a systematic approach only in the examination. Even when you write in the OPD, may not be possible. You write a case sheet, write the exam point of view. You do that, automatically you will learn. See, it is very difficult to remember so many things unless you do it again. So with the mobile numbers now, you know, the earlier days when we did not have the saving method, if I have no Thiru's number, I will know back of my hand. Now I will not know how to, because it's already saved there. That should come. The thing should be saved in your brain. Like that should be the computer where you don't have to think. But this is more important, more relevant to spine, mainly because you see spine, so many things are involved. You have a neurology which has to correlate with your findings, and you have to probably look at your spinal problem and neurological problem. Both has to be joined together, synthesized together. So your important thing is go in a systematic approach, whether it is a taking of a history taking, whether it is examination, and whether interpretation, everything should be systematic, because if you miss one step, let me say that you missed one finding in the neurology. You have, let's say you have missed a significant weakness. Your whole finding changes. You may not find all the muscles weak. Maybe the isolated tibialis anterior weakness with the spinal problem, it makes a difference. So if you miss one step, you can go wrong. And once your findings are wrong, your diagnosis is wrong, and everything comes. So the bottom line is a very systematic clinical examination. In your examination time, after your history, after your examination, you will talk of personal diagnosis, differential diagnosis, investigations, management. So I'm not going to cover it here. It is not possible because of the time. So, and also it depends on the case. So here I will be talking only about the clinical examination, which is first in the list. So examination of the spine, again, cervical, dorsal, lumbar, I'm not going to go into that because again, time factor. So let's say whatever case you get, if you can get a dorsal spine tuberculosis, you can get a lumbar spine problem. You may get a deformity of spine where it extends from cervical to dorsal or dorsal to lumbar. So the principle is almost same. Now, like anywhere else, unless otherwise you know your anatomy, whether it is for a disc problem with a root deficit, or whether it is, let me say, deformity,
this ISD call.
You should know your anatomy. If you don't know that, if you are not, anatomy is not right, you are likely to be wrong in your diagnosis too. So my talk will be on the history, something about clinical examination, and some special tests. Now remember, it is not possible in the exam to do, there are so many special tests, whether it's hip or spine, it's not possible to do all that. What is relevant to your case? Now, history in spine is probably, I divide it into three parts. Let's, for example, you talk about tuberculosis of spine with paraplegia. So you have three parts. One is the tuberculosis, that is the pathology part. Then spine, let's say it's a dorsal spine. So your spinal involvement is second part. Then paraplegia is a complication, that's the third part. So your history has to cover all the three. In the pathology, what is relevant, say if it is tuberculosis, what is relevant, right from the history of cough with the pulmonary, cough with respiration, loss of appetite, night cries, all those things are cold abscesses. Then spinal history, from the back pain to the other things, and neurology problem, from the bladder bowel involvement. History of bladder bowel movement is going to be very, very important for you. Clinical examination, except for a sphincter tone, you may not find anything. So all these things, unlike other areas, I divide mentally into two and into three and ask relevance. You all will know this, so I am not going to spend more time on the history. As I told you, general symptoms, local symptoms, according to area of involvement, ask leading questions. But what you might forget is a negative history. That is relevant. For example, let me say your case, a different diagnosis. I just given a random list there which you can see. But if it is going to be a case of, let me say, a deformity spine, and you are thinking the other possibilities, say ankylosing spondylitis, then you have to think of the negative history related to that. So that, because at some time, quite often in spine, like any other area, history can be very, very important. What are the major points? Where is the pain located? Where is the onset of pain? If it is a case of injury, relevant mechanism of injury. Before about the pain, diurnal variation, aggravating factors, activities of daily living, and what are the activities that have changed. All these things I am not going to spend time, because all these things are something which you know already are often located. One thing about problem with spine is, in the history, it's very difficult to isolate the specific location. Whether it is infection, whether it is trauma, it may be difficult. Then, when you have a pain, it is a radiating pain, of course you will come to clinical examination later, but at the end of the day, if a sensory blunting or a sensory problem, you are going to ask the patient also. So you should have an idea about the myotome or dermatome, and or the nerve root if it's a peripheral nerve root. So again, you have an idea. That again means anatomy. It's very important to know whether the symptoms are static or they are progressive, or are the patient deteriorating. Is the exacerbation remission? Now, just to go for an example which is totally not relevant to our what you are going to see is mostly compressive myelopathies and similar disorders. A pure neurology problem like demyelinating, you're not a case for you in the exam. But remember, these are also we should know, because say in a OPD setting, the patient is coming with worsening of symptom with a warm environment, like it may be a hot day, or it could be a hot bath or a sauna, the pain is aggravated. This is classical of a demyelinating disorder. It's called Uthoff sign, and probably the only thing in the history which is called by the name sign. So these are small things in the history. When the patient is telling you something doesn't fit in with normally what you know, we have to think of what is the relevance of that. So this is a few things I want to spend time. Smoking, please do not forget in any orthopedic patients, and drinking also, because we were always talking about a fractured union with smoking, but now it has come into also in the literature that alcohol, particularly within a particular level, can also affect the fracture healing, and it is also a neurotoxin. That also has come in literature. So anyway, you have to ask about it and ask about the occupation, etc. So I'm not going to go into details of the history. But when you present the history in a law, I know the setups have changed now. The examiner is likely to ask you, okay, what do you think from the history? Now, the common problem is when you ask what it is, you give a very perfect diagnosis. So it is tuberculosis of D5, D6 with a cord compression with paraplegia or something. Your diagnosis is perfect. Then when you are asked, okay, tell me what in the history told you about this, why do you help? You are not able to justify your diagnosis. That shouldn't happen. So you have to give your diagnosis, right or wrong, is something only you come after examination. At the history level, what you do is you tell what history you got, and depending on what do you think the diagnosis. Sometimes you cannot make a diagnosis. You can very well say, sir, I am not able to come to a diagnosis. But if you give a diagnosis, you should be able to justify. That's one thing is wrong. In spine, I prefer to start looking for starting your after general examination. We'll come later about general examination, but after your general examination, or even before general exam, the patient is coming, patient is already walking inside. If the patient is walking, start with the gates. This is because one thing, quite often, your spine cases are not ambulant. They may not be able to walk because of maybe myelopathy or maybe because of cord compression, where then your problem is solved. But if he is able to walk, it is probably better you start with that. Then you can start with your other parts of the thing. And I'm again not going to spend time on gait. The gait is very relevant in spine also. Say tuberculosis spine, the gait for a different gait in different level of lesion, cervical, lumbar, and dorsal. But even without that, we can say you have a cervical myelopathy or you have a cervical spondylotic myelopathy. The classical problem for the patient is the gait. That maybe sometime maybe the symptom for which patient comes, altered gait, is a wide-based gait. Or a proximal myopathy of the lower limb, again you can have a waddling gait. These are all related to spine. But even without spine, patient may be having an associated limb length discrepancy. Maybe there was a, this is the child who he didn't tell you, you didn't examine, he may be having a short limb gait. So observe the patient for any other abnormality of gait. If it is not there, well and good, but don't take it for granted that I look only at the spine, I don't look at the gait. Analgesic gait, a short leg gait, foot drop gait can be part. It can be a patient with a weakness of the dorsiflexors and we can have a foot drop gait. But even otherwise, do a general examination. So I am not going to that gait examination part. Coming to the general examination, it is very, very important because spine, you have to examine all the four limbs. So if it is a tuberculosis, there could be a cold abscess, skin cochlear spots, all that is there. So I'm just going to leave that and come into inspection. So look for any obvious swelling or surgical scar, look for deformities, look for loss of normal spinal curvatures, normal lumbar lordosis. It can be lost, it can be accelerated. Look for shoulder asymmetry, look for pelvic tilt. All these are standard what is given in the book. But it's important that you see the patient in standing position, a sitting position, supine and prone. If this patient is standing, in fact, if you can, you just make the patient walk, you will be, particularly a patient with a scoliotic list because of the root problem. You can see the gait issues, you will be able to make it out. But in a patient with a nerve impingement, there's a lateral shift of the gait away from the side of the spine. And a deformity like a scoliotic deformity of the spine can be a frontal deformity can be made out. Or any sagittal curvatures, whether it's an absence of a cervical or lumbar lordosis or excessive lordosis can be made out. And a wasting of the muscles. At the same time, you can look for spasm. You will see the back like a board, a straightened lumbar spine. Or there's a wasting, particularly in the deformities involving the capillothoracic areas. You can see the wasting of the muscles also. So all this should be looked for when you are seeing that. Along with that, there are some classical things described. Your patient may not be even relevant to your case. If there's a short leg, look for that. Look for short neck or for some things. But you have a patient, for example, you have a low hairline, you think of a Klippers-Winch syndrome. And when you think of that, look at this, look at the picture, you can clearly make out a high scapula on the left side, what is called the sprinkled shoulder or undescended scapula. In these patients, if you take an X-ray, you will find absence of cervical vertebrae, or you get a complete fusion of the cervical vertebrae, complete or partial. You might find that you just give an examination. This may not be something of the same deformities can be just simply made out by making the patient stand against the wall. This is not something which you may do for the examination, but in your OPD, when it's really saves you time, just ask him to stand against the wall, observe whether the occiput, shoulders, the buttocks and the heels are in contact with the wall. And particularly in children, you can easily make this out. It's very, very helpful in an OPD setting. So when you see the patient from the standing position, look for any alteration in the normal cervical lordosis, normal lumbar lordosis. There is always a kyphotic deformity, deformity of the spine, thoracic spine, whether it is altered, you can where it's more, you can see. And when you see that again, you should know if you are going to tell the examiner there is a increased complexity of the spine or there's an increased kyphosis. Quite often, he might ask you what are the different types. You should know about the knuckle deformity, angular deformity, and rounded deformity, rounded kyphotic deformity. You should know. You get the classical cause of a rounded kyphotic deformity of the dorsal spine is in a senile kyphosis. You will see quite often elderly ladies walking in with osteoporosis causing a kyphotic deformity. You can have younger persons coming with a Schwann disease, which is an osteochondrosis involving multiple vertebrae. And ankylosing spondylitis, you had a young adult male coming with this, a classical one. Moment he walks into the OPD, you can make out the deformity of the ankylosing spondylitis. Tuberculosis, still common. They are one cause of angular kyphosis in our country. Fracture or sometimes some of the congenital problems of the spine also can cause. And these are due to deformity. Knuckle deformity is something you palpate. Coming to the lumbar spine, look for a flattening or straightening of the lumbar spine or a reversal of lumbar lordosis. This could be due to right from a disc problem to tuberculosis, spine spondylitis. It can be a feature of ankylosing spondylitis also. When you have increased lordosis, one, it could be normal, for example, in ladies, it can be normal. But listhesis is a known cause for severe lordosis, or you have flexion deformity of the hip. The patient is compensating that by increasing the lordosis. So, or there could be a primary increased thoracic curvature for which patient may be again compensating by an increased lordosis. There are various causes for that. And when you see the patient from the back, first thing is you look for muscle spasm. Is there any scoliotic deformity? Scoliotic deformity can be postural. You ask the patient to bend forward, this deformity will disappear. If it's a structural deformity, the deformity with scoliosis will persist even when the patient is bending forward. And you might see a rib bump. If it has already come, if it's a long-standing one, deformity is rigid, you might find a rib bump. Other than this, from the back, you should look for the shoulder tilt and the pelvic tilt. Skin changes, particularly if you have a short case with a scoliosis or something, the examiner definitely going to ask you about telltale signs in the skin. The commonest thing, particularly you all know that if you have a CTEV, you look for spina bifida occulta. So changes which suggest a spina bifida occulta, it is not necessary it is only in lumbar spine. Please remember, it is not so common to find a spina bifida occulta in the neck also, cervical spine also, but it's quite rare. So what do you find? You might find just a pad of fat. You might find a soft swelling there, just a pad of fat, or you might find a tuft of hair, or a pretty large dimple, or there could be an altered skin change, color, or pigmentation. There is more skin in the more clearly seen in the fair skinned individuals. In our complexion, with the darkest complexion, the pigmentation may not be very clear. But equally important, you should look for heel sinuses or scar. There are other causes of pigmentation like cafe lay spots. I'll come to that next. And scar, if there's a scar already mentioned. Now swellings, other than for the pinna bifida occulta, swelling is important because you might find a large swelling which could be a cold abscess. And look for the prominent crease of the trunk. And now look for the wasting of the muscles. On the back muscles, what you look for the back, for the gluteus, hamstring, and the gastrosoleus group. So what you are going to do. Now, cafe lay spots, somehow all the examiners is a commonly asked one. What are cafe lay spots and what are the various causes, neurofibromatosis and fiber dysplasia? What is the difference between both? I think these are all theory questions which you know, but the question is you should know how the cafe lay spot looks. Again, a cafe au lait means coffee with milk, a French terminology, is much more clear again in a fair-skinned person. In our own country, the dark-skinned person, it may not be that clear as what is seen here. And this was a patient with scoliosis, rigid scoliosis, with multiple cafe lay spots. And if you have a spine-wide bifida occulta or a manifesta, they can have a paralytic deformities also. This was a child had a equinovarus deformity with a spina bifida occulta. You can see that child had clinical examination also will come, and you can see that there is a tethered cord also with that little bit, and this is what you call the tuft of hair. It's also called fawn's bird, and it's a hairy patch seen in the area. It can not very uncommon, but a dimple, a large dimple, or this was the same patient where you can see there is a fibrous band, and not, I don't know how much clear that is, but there is also some amount of tethering of the cord also was there in the child. This is a lipomatic swelling and a pad of fat in the area, and this is a problem. Sometimes you can get some other problem causing that, but if you have a pad of fat in the area, then probably you have to remember that. And this was a child with a large swelling there in the neck. You can see that pinna bifida here in the cervical area, and you can see that this was here. There was a pad of fat there, hyperintended shadow, and there was associated. You can see a diastematomyelia of the cord. Cord changes. This patient. All the pigmentations are not pathological. This is not very common. The name is funny. It's called a Mongolian blue spot. That is not only there. Quite often we see here, and at least 1 or 2 cases every year I see. Then you have a large spot. These are different, not like a small spot of pigmentation of a spina bifida. These are totally of no clinical significance, and they don't need anything to worry. This is spina bifida manifesta. You can see not just as you can see a swelling, bulging out, and you child had also neurological deficit. You can see make up the spina bifida manifesta, the CSF fluid coming there, and you can see there are cord changes also for this child. So these kind of patients also have neurological manifestations. So that was just to show a few examples. And coming to palpation, always the palpation starts with the warmth and tenderness. There is no difference in that. I'll come to that little bit later. If you have been examining the patient from the back, then continue to your palpation from the inspecting from the back. We were looking from the back, so I'm just continuing the same way instead of turning the patient this way and that way. When you are seeing from the back, you sit behind the patient, look for tenderness, look for warmth, and then come to the bony points, palpate the iliac crest and top of the iliac crest, and the line joining the top of the iliac crest usually goes in between the L4 and L5 this space, and then come down, palpate the posterior suprailiac spines, and the line joining them corresponds to S2, and palpate the spinal process, lumbosacral area, sacral leg joint, palpable muscle, and look for tenderness, any deviation, any from the vertical alignment and horizontal alignment. You find a step, you might find a step which is classical of epilisthesis. You can also feel the muscles which are quite rigid and hard if they are such spasm. When you come to tenderness, there are 4 different methods, which sometimes people again ask you what are different methods. The first is a direct pressure. You just you palpate the spinous process and give a direct pressure on that. It can produce tenderness, and particularly conditions like this. Or you can put a twisting strain. It's also called twist stress. You can just put a rotational stress on that, indirect movement. Third is what is called a deep thrust tenderness. The R is left out, so the spelling mistake there. It is deep thrust, T-H-R-U-S-T. And you put a deep thrust. One simple way of doing is a gentle percussion, but it may be very painful, so you have to be careful about it. You can put a deep pressure on that, and we'll test routinely. We tell you not to do, but just for knowledge, you should know that it's not safe to do that. But if you are in doubt, if everything is negative, then you can go for the anvil test, which I'm sure all of you will know. So when you look for the tenderness, as usual, look for along the spinous process. Also look for tenderness in the muscle. One of the common example I'll give you is trapezius. But if you, for example, a triple cervical spondylosis coming to you with a spasm of trapezius, you just palpate the trapezius and put a pressure on that. It will be so painful. Half the time the pain may be due to only spasm of the trapezius, or many other conditions like polymyalgia, polymyositis, or even a fibrositis. You can have a tenderness of the trapezius. Circular joint tenderness, as you know, is a very important finding because circular joint is difficult to test when there is associated hip deformity. And a step of spondylolisthesis, you slide your finger along the lumbar spine towards lower down. You will find a palpable step at the lumbosacral junction or in the lumbar spine, depending on the level of the listhesis. Same thing applies to thoracic spine. You should know. As I look at thoracic spine, you have a little difference. You have not only the spinous processes, you have supraspinous ligaments, you have costovertebral joints, you have the trapezius muscle, you have the paraspinal muscles, and you have the scapular muscles. So, but this may not be important from the exam point of view, but practical point of view, it's helpful. In the lumbar spine, it is the lumbar spinous process, paravertebral area, and a step of deformity in the listhesis. Coming to sacrum and pelvis, you should know that what is the medial sacral crest. That is your medial sacral crest. It will come when we talk about the Schauber's test. And the iliac crest, as I told you, a line joining both the top of iliac crest goes between the L4, L5, and that is the sacrum, that is L5, and that is L4. And posterior superior iliac spine, gluteal area, ischial tuberosity, retrocandor, and pubic symphysis, if you want to be thorough in your examination. Movements, we have a big advantage compared to the hips, etc. But again, please remember, when you look for movements, even in the spine, it is not that there is no passive movements of the spine. Normally, we don't do it. But we should at least be aware. So I'll just mention, it could be active range of movements, it could be passive range of movements. In fact, there's a third one called assisted movements, which is not necessarily at this level, so we'll not talk about it. So active range of movements, you look for flexion. How do you do it? Ask the patient to bend forward, and touch the ground or touch the toes. You can measure it by the distance from the tip of the finger to the floor. You can also go up to the, compared to the anatomy, you can say about how much of the leg patient is able to reach. But commonly what is described is from the distance from the ground. And this can be affected by hamstring spasm, even affected by there is a contracture or a spasm of gastrocnemius, or there is a paraspinal tightness. Not necessarily only a spinal problem. Extension of the spine is almost similar. You ask the patient to look backwards, and here usually don't measure that by touching anything. It is only what eyeballing, how much patient is able to do that. And lateral bending, you measure the distance from lateral bending. You measure the distance either from the tip of fingers to the floor. That's a large distance. So normally we say patient is able to press up to the proximal part of the patella or knee joint line or what part. You look at the distance between the tip of the fingers and anatomical part relevant, either the leg or the knee or the thigh. If is able to come only up to trochanter, then fine. So whatever you are able to do, that's how it is talked about. Rotation makes the patient sit. Rotation is helpful for many things. It is also one of the methods of looking for a problem of the circular joint. Make the patient stretch, stabilize the pelvis, and ask the patient to turn without movement of the neck to both sides. And that's how it is done, patient, how much patient can turn. These are the active movements done in the spine. It is a lateral bending again. These things can be measured. I'm just going at the same time to measurement also. Some people have asked me, sir, can you measure all these movements? Yes, you can do that. For example, if you are taking a lateral bending, you have your goniometer, put the fulcrum on the S1 spinous process and the stationary arm over the median sacral cleft, what I showed you in the picture, the median sacral cleft. Then you adjust the movement arm, which should be aligned to the C7 vertebra or the most prominent cervical vertebra you are able to palpate. And that will give you the amount of lateral flexion. Similarly, for the rotation, you keep the fulcrum over the center of this head and keep one line parallel to the acromion process and the other one parallel to the shoulder, parallel to the trunk. So that's how you do that. But usually we don't expect you to do all this in the exam. We only ask you about the movements. Even if you talk about with the level of the fingers, that is usually enough. We rarely expect you to do that, but you should know. If they ask you, you should know. Now, all of you will know for showbusters, all of you will be asked, most of you will be asked, most of you will know. But it doesn't mean that showbusters measures only the movements at the lumbar spine or the amount of bending producing how much length you gain. But that is not the only measurement. You can measure entirely the movement of the spine. You can put your inch tape from the most prominent cervical spine to S1 and see how much it is. Ask the patient to completely bend forward, touch the toes, and you measure. And that will give you the total flexion of this spine. And the reverse, you can do the extension also and say how much distance comes down. Usually, again, we don't really, because mainly that is because if we are viewing this, that let me say that you are looking at ankylosing spondylitis. It is very easy to make out just by looking the lumbar spine. That is the only reason, but some conditions are there where you can do for the whole spine. Passive range of movements, how can you do that? It's again, you can do for the, in a child it may be easy, child it may be easy, but even in adult, that is how you look for flexion and extension. You can help the patient do that. And the third, you can put your hands on front of the chest and lift the patient up. Once you do that, then you can let him rest on his upper limbs, on his elbows and wrist, and you can do the measurement. And that is the third picture, is the rotation in passive. But as I told you, this is just for you to know that it can be done. We don't expect you to do this in the examination, so this is not to tell you to do that. But you should know if it's asked. Measurements, there are two things important. More than anything else in spine, these are what they're going to ask you. The examiner usually will ask you about the neurology, ask you about SL, straight leg raising test, ask you about shoulders. And chest expansion, in any, particularly in a male, young male coming with the back pain, you should have to do it routinely. Now, what is the importance of shoulders test? It assesses the amount of lumbar flexion. In a lumbar spine flexion, the hip can Hip flexion compensates for a considerable extension. If you lose the spinal flexion, the hip joint can compensate. So you may not find the patient to have a disability. You may not bother about it. That is why you should do a Schauber's test objectively to measure the spinal flexion. So that is something the patient may not tell you. So you have to look for it. Now there are two ways how you test for a two ways given in the book issue. One, you look at what I have marked as number 2 is the dimple of Venus. You draw a line joining both the dimple of Venus on the right and the left. Then draw a midline, and where it cuts the midline, mark a point 5 centimeters. Suppose we draw a line joining both the dimple of Venus, that's the midline, 5 centimeters below, 10 centimeters above. So this line is 15 centimeters. Now ask the patient. So okay, we'll come to the second method now. Suppose what happens sometime a thin patient, a dimple of Venus is seen in a very obese patient, or in some patients you can't make out. Then what do? You look for a posterior superior iliac spine, PSIS. Yeah, that is palpated, mark that. Draw a line joining both. Then again in the midline, take 5 centimeters below, 10 centimeters above. So the only difference is the transverse line is either from the connecting the dimple of Venus or a posterior superior iliac spine. So this first stage is the only difference. This stage is same further. After that, whichever line you take, ask the patient to touch his toes or bend forward, and this should be minimum about 5 to 6. If it is, let's say that it is normally should increase to minimum, at least should come to 21 or more than 21 in a normal patient. If it is less than 5, then it is significant. This can vary to a great extent too, but more or less reliable. There is also, like you talk about finger brands, some books are given a finger type examination, finger method of examination for Schauber's also, but it's not as dependable like a finger brand. So what you do, you place your fingers on the lumbar spinous process, and you take a line, lower lumbar spinous process, like say L5 or something. Take a line 10 centimeters, put your highest one finger, palpate highest level above and highest level below, and as the pen forward, you will find your fingers moving. But again, this is not very reliable. I don't think you should talk about it. If the examiner asks you, just for you to mention. If the distance between the two fingers is less than 5 centimeters, when you move, it shows a limitation. So this may be helpful for you in an OPD setup where you don't want to spend your time on cleaning the patient. Then later, when in the ward, you can draw the Schauber's test. Beyond that, you will come to the other part of general examination now, because here in spine, for example, at this stage, if you think that patient has to be examined for say abdominal problem, patient is relevant, or you want to look for a cold abscess either in the iliac fossa or in the psoas area, all that has to be done. Then come next is going to be the neurology. The neurology, before you go to neurology, proper to examine the neurological deficit, first thing you are looking for a nerve root irritation or a nerve root problem, and that you are going to do by a straight leg racing test. This is one of the things which is commonly asked in the exam. After doing that, you do a neurological test, which includes motor, sensory, reflexes, and then you go for a rectal examination. Now, coming to the, we'll come to the straight leg racing test a little later half. When you go for a motor system examination, please remember, even if your problem is lower limbs, examine the upper limb also, at least, examination in brief, so that a gross thing you don't miss. You should look for, again, inspection. What are you going to look for inspection? Abnormal contractions in upper motor neuron lesion. You may find abnormal contractions. then you look for the tone, you look for the power, then you come to the deep tendon reflexes, superficial tendon reflexes, and test for coordination. Now, when you look for the tone, it can be hypertonia, normal tone, or hypotonia. This really helps you to know about whether the lesion is a upper motor neuron lesion or a lower motor neuron lesion. So yes, if you want that, this is something which is not difficult at all. Because once you know it's upper motor neuron lesions, then you are going to doubly look for your Babinski, which sometimes can give you trouble. So it's better to start with the tone. You know that. Then comes the power. Power again, it's not just looking. Let's say you are going to look for a C5, you are looking for abduction of shoulder. You have to know, as I said earlier, a dermatome, myotome, or root value. This is going to be important because your upper limb, the lower limb pathology, you want to save your time. You don't have time for doing everything. You do a shoulder abduction, you do an elbow flexion, you do an elbow extension, then you go for your finger.
Sir, your voice is not clear. Your voice is breaking, sir.
Sorry, I don't know why. Is it better now? Maybe my vocal cords are tired, or maybe
no, sir, still...
I was just hoping that our Wi-Fi will not pull our legs because...
Can we just take a break, sir?
No. I just moved backward. That is why your voice faded away.
Now it's better, sir. Now it's better.
If it is still not all right, that's why I kept my mobile ready. I'll put the voice
no, sir. Now it's fine, sir. Now it's fine. Now it's fine.
So you suppose your problem, you are dealing with let's say a lumbar disc prolapse, and you are just doing a routine checkup of the upper limb, then you have to be very, very fast on that because you won't have time. Just for looking at shoulder abduction C5 and elbow flexion C6 and wrist elbow wrist extension C7, that plus your fingers, adduction and abduction of fingers. So you can just do a brief analysis if it is a lower limb problem. And fingers, as I said, adduction, abduction is C8T1. So you can do with that lesion. So you have to know their levels. Coming to the reflexes, start with superficial reflexes. First do Babinski, then other superficial reflexes and deep reflexes. Again, this is very, very important. One, it needs practice. Number two, and this is what I said. Instead of remembering this, if you write your roads in the ward patients like properly, every time you do a examination of a spine patient, you do all these jerks and write down the value there. You don't have to think. Automatically, it comes to your mind. After all, there are only 3 deep reflexes: biceps, triceps, and the supinator jerk. So you should do that, and it's by routinely doing only you will get it. When they ask you to demonstrate, you will demonstrate beautifully in the exam. Grading of the reflex, nobody going to ask you unless you are doing very well. There are different methods. It is not same as what you just write brisk or this thing. So where there is a sustained pronus, that becomes 5+. And normal is 2+. And if it is brisk, more than normal, it is 3+. Very brisk with a hyperreflexic, it is 4. A sustained pronus is 5. If it is low, just a low normal is 1+. And you are only getting with the reinforcement, that is 0.5+. And where there is no response is 0. As I told you, this is only in case you do very well, they are asking this. Babinski, please remember, this occurs naturally in the newborns, but it ceases quite quickly after birth. And this is something which you are going to do again and again till you are, and it needs practice so that you don't miss this, because that's why I said you do the tone, reflex is exaggerated, then you know your Babinski should be positive. Sensations, what are the sensations you do? This is the commonly asked to, people ask me in the exam. People ask me, what do you do in the exam? Ideally, you should do all the things. You should do a light touch, you should do a pinprick, temperature, hot and cold, proprioception, judges the joint position sense, vibration sense, and 2-point discrimination. This is what you are expected to do. If time doesn't permit, then you can probably at least do the light test and pinprick. Now, if you have time, you should ask for that temperature, should have a tuning fork with you. This is what is expected, but it all depends on the examiner. But ideally, I think should be at least carrying with you the tuning fork. Now let's go back to that now. So the important thing is not looking for sensation. You should know. For example, it is not very difficult at all. So if you start area, for example, your regiment barge area, that is the C5. Then you come to the lateral part of the forearm, that is C6. Your middle finger is C7. Your ring finger is C8. And medial part of arm is T1. So that's very easy to remember. It is not difficult, but again, it's more than remembering, is doing it automatically. Your brain will remember for you. And just like the upper limb, the lower limb again, tone, power, you have, of course, different muscles. You start with the hip, knee. You may not be expected to do individually all muscles unless otherwise particular case. Let me say you are going to have a facioscapulohumeral type of dystrophy, then you have to examine only a few muscles. Or in a particular case, like if you have, say, a deltoid weakness which is relevant, they may ask you. Otherwise, you go by group muscle, and wherever you find, for example, if you are finding, if you just say that hip flexors alone are weak, then it's a different issue. Otherwise, you probably don't have to do for every the examination within the time prescribed. You may not be able to do. But suppose your case is a disc prolapse, and that is going to have a tibialis anterior or a EHL weakness. Then it is not the dorsiflexor. You have to talk about power of the tibialis anterior, power of tibialis posterior, and EHL. So power of the hip flexors, hip muscles, knee muscles, ankle, and also about the tarsal joints. All that you have to remember. Reflex, knee reflex, ankle reflex, plantar reflex. I'm just going fast in that because this is all given in the book. Sensations, just like the upper limb. For example, if you are going to put your hand in your pocket, that is going to be equivalent to the L2 area. Just above that will be L1 area, just below will be L3. That's how you remember. And you should know about the lateral part of the leg being L5, and lateral part of the foot dorsum is S1, and posterior leg is S2. Now, special test. There are many special tests, but in the exam, usually it is only a straight leg raising test. I don't think many people will bother you with all those things. So I will be going mainly to the straight leg raising test. Now, straight leg raising test alone, we can probably discuss for 45 minutes to 1 hour. Neither time permits nor my voice permits. But what is important is that there are so many tests which have been modified. Lazigay test itself, he described one. It has been modified by 2-3 people. You take Brega's test, that has been modified. It is not necessary. For example, if I am doing in a clinical setting, I do only bowstring test because I'm happy with it. I'm used to it. I just only do that. You also can do one test in the exam, but you should know the other test. You do not have to do all the tests described in the book. Now, what is straight leg raising test? It is a test for knowing about irritation of a lumbosacral nerve root, which may be due to disc prolapse or any other cause, but your idea is to know, is there a tension, is there a nerve root tension or a nerve root irritation? And if you are going to know which root is going to be involved in each level, whether it is in L4, L5, what root will be involved, you have to know the anatomy. We will leave that. Let's know how to do that. What are the prerequisites for doing a straight leg raising test? First of all, the most important is a normal mobile hip. If you don't have a movement in the hip, how are you going to do that? There should be no FFD at the hip joint, because if there's FFD, the patient will be compensating by lumbar lordosis, and if you correct that, already the hip will be in flexion. So again, you can't do that. There should be no hamstring strain or spasm or a contracture. And patient should be intelligent and cooperative in the sense, otherwise he'll keep on, at every time you move, patient already knows that I have to howl, then only it will be positive. People who malinger, and that will be a problem. When there should be no significant exaggerated lumbar lordosis. Now let's come to one by one. So a simple, straightforward one is just put the patient, and remember, it is not an active straight leg raising. Patient is not the one who has to do it. Patient is on the back, relaxed, lift one leg and keep the knee should be completely straight and keep lifting up till the patient experiences a pain similar to the pain he complains of or similar to a nerve root irritation. The pain should be felt in the thigh, buttocks and the calf. Record the angle at which pain occurs. In any normal patient, even by 70 degrees, you can have pain. It depends on, or if it is a gymnast or with a ligamentous laxity, it can go up to 110. But 80 to 90 degrees, I will even say 70 to 90 degrees can be taken as normal. Now, at this level, when the patient complains of pain, that is where the augmentation comes or the complementary test to look for a nerve root tension comes. So these are called sciatic stretch test. Either you can dorsiflex the foot, and if this gives patient a discomfort, a pain as it occurs, he suffers, then the test is positive. That is actually simple test, that is enough. Now, there are so many modifications that, so what happens, what did we do? When the patient has the limit where patient is comfortable of straight leg raising reached, you do a dorsiflexion of the ankle, it produces accentuation of pain, then we call it positive. Now, does that mean that the pain is only because of a herniated disc producing a root tension? Not at all. If patient is having a, let me say, a polymyositis or a polymyalgia, or he is having a myositis due to some other cause, or he is having ischial bursitis, it could be even an annular tear and hamstring or a hamstring tightness. In all these conditions, patient will have positive. That is why we said there should be no hamstring tightness. Now, if the patient complains of pain even before you lift the leg, which quite often happens in the OPD setting, he may be malingering, or there could be some other problems. It may not be due to disc prolapse, because in a disc prolapse, the nerve is not stretched before 20 to 30 degrees. So if patient has even on 5 to 10 degrees, you have to think of any other cause for, any other explanation for nerve root irritation, whatever those causes are. Now, this is all that, actually speaking, in my opinion, one needs to know about straight leg raising test. But examination is examination. People may ask you what is Lazige, what is Bregard, Budinski's, Kernick's, bowstring, etc. Now, Bregard test is a complementary maneuver like that. So here, there are again different modifications, but one which he described is where the straight leg raising becomes positive, you slightly reduce the angle. The previous one, the leg is kept at the same line. Here, he reduces the angle. The leg is lower to the less from the positive. It was positive at 80. Bring it down to 70, and you do the dorsiflexion. That is causes a Bregard test. The difference between the other one, previous one, you did not reduce the angle. A similar modification by what is called modified Lazige. There, your knee is slightly, you have the patient as the pain, gently flex the knee, the pain will disappear, then gradually extend the knee, the pain will come. Advantage of this is that it differentiates you from the hip joint pain, because you are producing the pain with a movement in the knee and not movement in the hip. But by principle, all of this are same. Kernick's test and Budinski test is almost similar for me. Again, you first start the, okay, you start with the patient lying down, raise the leg. When the pain occurs, flex the knee slightly, the pain will subside, and you do a cervical flexion. Bend the neck to further stretch the neutral elements. Instead of dorsiflexing and stretching the nerve, for example here, The picture, of course, it is shown as active. That is wrong. Do a passively. Slightly bend the knee. Now he is bending the neck. Again, the examiner is bending the neck for the patient. And if the reproduction of symptoms, it is positive. Bolstering sign is a little different. That is, you do a straight leg resting test where the pain starts. Slightly bend the knee, maybe about 10 degrees. The pain will disappear. Give a popliteal compression. What do you do by that? By applying compression to the popliteal fossa, you are putting pressure on the sciatic nerve like a bow and a string. The bow is the knee joint flexion. Sciatic nerve is the string across. This provokes symptom to a lesser degree of SLR. And big advantage of the bowstring sign is that if there is a hamstring tension irritation, moment you flex the knee, the hamstring tension irritation goes off. Not a hamstring contracture, hamstring irritation. And you press in the midline. Hamstrings are not this thing. And if it is provoked, that gives you. So you can do a classical SLR or any of this. You have to do only one, but know the others. What is more important is a cross the SLR. That is very, very important. You do a straightening testing on the unaffected side. That produces pain on the affected side. That is crossed SLR. This is something very, very important because SLR is very sensitive but not specific. Whereas crossed SLR is very specific but sensitivity is low. These have been described in literature in 1972 issues, nothing new. Now, what is the sensitivity? SLR got a good sensitivity of 91%. But specificity is only 32%. That means if you do SLR, if it is negative, you can probably say that patient is not having a nerve root tension. A crossed SLR is highly specific, more than the sensitivity of a straight leg dressing test, because it is highly specific, but sensitivity is 32%. So in other words, if you want to confirm the disc herniation, then you see that what is important is a specificity. So crossed SLR is very useful for ruling in a disc lesion. Now, quite often you get, not from the exam point of view, but quite often you get a patient who is malingering or who is out for some other reason. There is also one test called the seated SLR. Make the patient sit in the edge of the bed with the knee at 90 degrees and the leg hanging free. Gently extend the knee, but the thigh should be on the bed only. And patient, again, this will be equivalent to a nerve stretching. Patient will go back with both arms extended and he will have pain below the knee. This indicates a sciatic nerve involvement. So if a patient is trying to malinger, he may not know about seated SLR. If he knows, that is a different picture. So this is one where you can try to make out. This is one way of making a called a seated straight leg test. Now there are special tests described for malingering. One is a reverse sciatic tension test. Now sometimes in the book, some of the books you find a reverse sciatic test by some other test, but I don't want to say that right or wrong, but actually a reverse sciatic tension test is different. That is, after doing SLR, instead of dorsiflexing the foot, you do a plantar flexion. Definitely this should not exaggerate the pain. But patient complains of severe pain with this, then probably he is malignant. So this is not a reverse SLR, it is a reverse sciatic tension test. Whoever has described 4 ways to make out malingering. Sometimes asked in theory, some examiner may ask you, what are the things? One, our patient lies supine. You keep your hands under the heel of the patient. Ask him to raise the leg on of the leg. He will not do that. Without his knowledge, he will be putting downward pressure on the unaffected side. If he is not putting the downward pressure, then patient is not giving effort. He is not trying to lift at all. Bladder signs, one, the findings will be non-anatomic. For example, if you pinch the skin also, he will say there is a radiation of pain. And if you give an axial loading on the head, it will not replicate the back pain. And if you distract the patient, like simply do a seated SLR, it will not be possible. And there will be non-physiological pain. It will not follow any nerve roots. And when you are doing for a strengthening of the chest, he will release the muscle contraction. So you will know that he is malignant. Now, all we talked about is for the lower nerve roots supplying the area. But if you have a femoral nerve irritation, then you have to do it the opposite way. Here, you are looking for extension of the hip, not the flexion of the hip. When you do SLR, you are flexing the hip. Here, you put the patient's prone and you passively extend the hip by keeping the knee in 90 degrees. The pain will be felt on the anterior and lateral thigh. This is an irritation of the L2, L3, L4 nodes, or it is called a femoral stretch test. One of the conditions where you find it is in hemophilics. Sometimes they have retroperitoneal hematoma and they come with a femoral nerve pressure. Or it could be, of course, a problem of L2, L3, L4 roots. So this actually, you are doing the reverse direction of SLR. Some people call it reverse SLR, but the right is only a femoral stretch test. And the same way in the picture how it is done, that's how it is done. So you put the patient prone and lift the leg and produce the pain. So what I already told you again, sorry. Okay. Now, at this stage, if you have time, if it's relevant in the examination settings, if otherwise, you should definitely do it in all the patients. You look for abdominal extension, to look for abdominal mass. Quite often, your diagnosis can be entirely wrong. You will be surprised that I know of a patient whose patient's wife was a gynecologist. He was being treated for tuberculosis of spine, and patient had no relief with the treatment. Palpation of the abdomen clearly showed a big mass in the abdomen, which learned to be, when palpation was very clearly seen, and it happened to be a renal cell carcinoma, hypernephroma, kidney tumor. So you have to do that. Coming to rectal examination, yes, it's important definitely in your practical setup, but coming to examination, you don't have to do it. Of course, you have to take consent of the patient. Before that, you ask the examiner or the local assistant, should I do a rectal examination? Can I go ahead? You can ask, and then you can go to do about it. It is important because why? We will come to that later. Then also look for peripheral pulses. Peripheral pulses should be checked because a vascular claudication can mimic symptoms of radiculopathy or even a canal stenosis. So pulses you should palpate. Coming to why it is important to do a rectal examination. Imagine a setup in a patient with a cardiac equina syndrome. He comes with low back pain, pain in the legs, and let's say that you have missed your findings regarding the motor or sensory deficit. Bladder function, as you know, you may not be able to make out unless your patient is there with a distended bladder. But if you do a peritoneal examination, a loss of venal tone or sensation or a pagel anesthesia, you make out, you will not miss. So it is definitely important that you do it. But in the examination, I tell these things, and whenever they ask me, I said, don't do it in the examination setup because patients are kept for another person also. So after this stage, when you have taken the history, you examine the patient, now comes the most important. You have two things here. You have the bony level of the lesion and neurological level. When you come to neurology, first thing is to know whether I'm dealing with the upper motor neuron lesion or a lower motor neuron lesion. Then, what is the neurological level? What is the motor level, sensory level, and reflex level? If your motor is say D4, Essentially, this reflex is much below. You take the highest level and corresponding spinal level. As you know, cord ends at the level of L1. So the bony level and the neurology level is going to be different. So when you present, you say you have a neurological deficit. It's the upper motor neuron lesion. My motor level is this, sensory level is this, reflex level is this. So my neurological level is C5, C6, whatever it is, spinal level. And then you give your diagnosis. And when you say the diagnosis, it has to be complete. You can say, for example, I'm not going to the first level, whatever you say, okay, tuberculosis spine or disc herniation, whatever it is, your neurology is a root problem or a cord problem. If it's a cord problem, what is the level and what is the spinal level vertebral? We have to give a complete diagnosis. Your clinical examination ends there. Now you have come to a different stage. Examiner will ask you, what are the other possibilities? Will you entertain a differential diagnosis? If your findings are completely fitting with your diagnosis, there is no need to give a differential diagnosis. Don't fall into that trap. But let me say you have a problem. Sometimes, maybe a shortage of case, they might have kept a case which is very difficult for your level. We will not bother about diagnosis at all. Your findings becomes important. Here you say, sir, I am not able to give a diagnosis. These are the findings. It could be any of this. This is fully fine. But when your findings are very clear, you have only one diagnosis. You don't have to give a differential diagnosis. And then it continues with your investigations, management. I am not going to go into that. I'm just repeating what Prathiru said in the beginning. A spine case looks difficult, but with practice, it is very, very simple. Nothing is impossible. It just looks impossible till you do it. With that, I thank you for listening. Now, with the permission of Thiru, for any questions, if anything you want. Let me tell you that I have not covered everything. One, it's quite, in my opinion, nobody can be attentive for more than 20 minutes. So this has crossed that limit. So that's why I left out so many things. Thank you.
Sir, I think that was, I think you wonderfully covered everything, sir. Of course, 1 hour, we really put a strain on your voice. I can see that. First, I apologize for that. And next, thank you really so much for, making it so simple for the postgraduates and giving them the confidence that spine can be easily, it can be done in the exam. It will not be a huge problem. And so we'll, I think Ram Prasad is ready with the question, sir. So Ram Prasad.
Just a small statement on that.
Yes, sir,
this is not because of, it's my problem that I have a thyroid problem. It's an nodule. The surgeon told me nothing to do. So if I take a class for 1 hour, at the end of that, I can't talk for some time. So don't worry about it.
Sorry, sir. I thought that's what I thought. We could take a break for 5-10 minutes in between.
No problem.
But you want to continue, sir? Okay, Ram Prasad, please go ahead. No
problem. Sir Rajagopal, sir. Good evening, sir. It was a very good presentation. In fact, this now shows your stamina actually. So yes, for minutes and more also. Hello, am I audible?
Yes, sir. Yeah, I'm listening to you. Thank you. Thank you,
sir. And as you have exhaustively mentioned the clinical examination, most of the PGs should be thinking with this X-rays, CTs, and MRIs at our disposal. Why should we go for such a elaborate? But I think an MRI may show a pathology, and the MRI-based pathology should not be taken into account for planning the procedure. So if the patient has got a real clinical examination finding, whether it is in history or in physical examination, then only the relevance of operating on that particular pathology in MRI will be countable. Otherwise, it's not going to give any relief to the patient if the surgeon is going to operate based on the MRI findings alone. So in that perspective, the clinical examination becomes very, very important, even in the future generations for orthopedic surgeons. Am I correct, sir?
Very, very true. I am happy Ram told about this. Plus, please remember, if my clinical findings Do not match the MRI. MRI is not important at all. It is your clinical findings, your clinical diagnosis. MRI can confirm your diagnosis. But if the patient is not having symptoms and signs of that, I will tell you one simple example. A colleague of mine, more than 30 years back, 30 years or 20 years, I tell you 90, 93, 96, so how many years? 24 years, had back pain, multiple lesions in the spine. It was not tuberculosis, but somebody had put ATT and she had taken the full course and pain disappeared. The pain would have disappeared even otherwise. The whole problem was doing an MRI. Your clinical findings, your clinical findings should match. If it is not necessary, I will even say you don't need a MRI for every case that you see. And MRI findings, please remember, MRI has got its own drawbacks. The sensitivity of MRI is so high that it's okay, it's very, very, very useful investigation. But please, what Ram said, 100% you don't treat by any investigation. Clinical findings are very, very important, but MRI particularly can be extremely misleading.
So there is one more question from the chat box, sir. Can I just read the question? Sir, if SLR, this is from Dr. Jitin, I don't know which institution he belongs to. Sir, if SLRT is positive, should the pain be experienced in all the three sides? That is the buttock, thigh, and calf. Or so that's his question. Should the pain be experienced in all from the so proximal level to the distal level? Should the pain be there all the three sides?
Justin, the answer is no. The pain is supposed to radiate along the nerve root. Radiating along the nerve root not necessarily involves all the area. The patient has come to you with a pain, and why this varies, as I told you, the nerve is a highly sensitive structure. If the nerve is compressed for a long time, you lose all the sensation. For 2 years, you keep compressing a nerve, there will be nothing left in that. So, depending on the compression, suppose the patient had only a pain, let me say, radiating along the lateral aspect of the leg. That pain should be reproduced. That is the answer. But the pain should radiate along the distribution of the nerve root. That is the answer given in the book. But it should be, like you said, if the patient doesn't come to all the areas, if radiation along the area where previously we had perceived the pain, then only it's different.
Perfect, sir.
Now can correct me if there's a difference of opinion.
Hello? Sir, how can I do that? When you have made a statement, it has to be true.
You can see. That's one thing I learned from my chief, Dr. Yadav. He will allow us to question, talk. You can openly discuss with him. We were bachas that time, but liberty as far as science. Science, knowledge has no age.
So as you said, the diagnosis part is very important, not only for communicating with the examiner, but also for planning for treatments. So as you said, the diagnosis should be divided into different things like what is the actual motor level, I mean, whether it is upper motor neuron or lower motor neuron, it is spastic or flaccid. And then it should also include the motor level, sensory level, and reflex level, and then the vertebral level, and finally the etiological, that is the pathological problem, whether it is trauma or it is tuberculosis. So we have to mention that also. So this diagnosis should have all these components in it, so that the PG can get a good mark.
You know, Ram, one reason for telling that, see, if I appear for the exam and Thiru is the examiner, I will be tense now also. Exam is exam. In the exam, they will be tense, they will forget. They will forget. So that is why I am telling this. That is one thing, I totally agree with you. Whether you should be that much exam oriented, Actually speaking, no. Our training should be for him to make a good orthopedic surgeon, not a good person to just. But at the same time, it hurts me. Somebody who has worked for 3 years, read for 3 years, on one day he doesn't do well, he fails. That also is not something which I don't want any of them to fail. So that's why he has to balance both. It is not just passing the exam. He should know. I totally agree with you. But how much ever you tell that day, because the tension they make. So that is why if he leaves out one, there are people who will put marks for that and reduce. That is why I stressed again and again. But definitely in real life, it is very important. You treat a tuberculosis spine without knowing there is a neurological element or not, it's also going to be bad for the patient. I totally agree with what you said.
Actually, the PGs are thinking that spine case is the toughest case in examination. But according to me, it was a blessing in disguise for my examination in MS Ortho. I received a spine case for a long case, sir, actually, because I went to the exam hall 5-10 minutes late, and the skilled assistant was angry with me. So he allotted a spine case, that is a tuberculous spondylitis with paraplegia for me. So it was a paraplegia case, and there was an obvious deformity in the spine. So for me, it was very easy to go through the examination and present the case, and I went through the examination, passed very easily in that case actually. So I that instead of a hip case, a spine case is easier to examine and get a pass.
Ram, I think that was an induced anger. I think you've done it, I think he's played on the. He's been smart enough to do that, sir, in exam.
No, Thiru, I'll give you another example. Just the opposite of that. See, of course, I shouldn't tell the place or the name. In one center, I had two candidates. One was first time, other person was repeater. I knew that this fellow is out of touch. If I give him a hip and he makes a blunder, I can never help him. So I gave him a spine case. He kept on saying he doesn't want, because spine he makes a little bit of a mess. I can still help him out. The examiner also has got the thing. He wanted only the hip. So I changed and gave that. I didn't want him to be unbalanced from the beginning. Removed the spine and put a hip for him. But he didn't understand. I did with the idea of helping him, because it is still, discussion and everything. He won't get stuck with the Trendelenburg or telescoping, which he goes to say is the opposite. The examiner may not pardon him. So this, even when you try to help, still that fear continues. I don't know how long it is going to take for that to go.
Sir, I think the most important point.
Sir, there is a question.
Yeah.
Whether in a spine examination, we have to start with, as you said, you will start with general examination. Whether we have to include the higher functions of the brain as well before coming to the spine exactly.
Yeah, good question. Actually, I forgot to, because in fact, if you notice something, I never kept general examination in my slide, because if I start that, I know I will go tangentially. Now, the thing is, yes, let me be a little bit frank in that. Whether you do or not, when you are starting your examination, neurology, higher functions and cranial nerves, normal, you start like that. You need not do everything. You got a brachial plexus injury. Look at ptosis. You don't mention that. You got a cervical spine tuberculosis without neurological deficit. You know that patient can have glossopharyngeal nerve, paralysis. You can arc and open the mouth. You will see it. So you have to know what is relevant. But otherwise, naturally, you won't be testing all the cranial nerves. But you are, if the answer question, if you ask me, am I supposed to? Yes. Theoretically, yes. Practically, whether if you don't have time to examine, at least see that there is not something like ptosis obvious. But you have to start your examination with higher functions of cranial nerves now. We are also human beings. We know that you don't have time for that. And so we leave you, unless otherwise it is relevant to that patient.
So I think the most important point is to the PGs. I think very important message that he gave to the PGs is, when they write the case sheet, when they do one case of examination of spine, I think they have to do it very meticulously, at least 10 cases of spine before they complete. If they write the case sheets clearly, do all the clinical examination. I think that was the important message that you gave, so that we do, specify sometimes, but the PGs don't understand the importance because they don't have time, or they don't think it is very important for them. But to write the case sheet, to mention each and every test, to mention the levels of, if they do that at least 10 times, I think they're not going to, the brain is never going to forget. Even the subconscious mind will definitely, I think they will realize how important this is, especially the neurological examination. I think that point you mentioned very clearly, sir. I think that is the most important message today, sir.
Thiru, I did that in St. John's. It was compulsory for all the postgraduates who are presenting the case, write the case sheet, ask in the exam and give it to them before presenting. All the case sheets I made, particularly with the NABH, it was useful. There was a page for PGs to write. Insisted that they, not all the case, which is relevant from the exam point of view, write properly. That really improved their presentation standards. I think that is something very useful for them and also useful for the patient. And tomorrow, the way things are, records are going to be important. So it benefits everybody. Benefits the hospital, benefits the resident, benefits the team.
Yes, sir. And about the PGs, I think you can go ask. I think we don't, let us not trouble sir too much. If you feel it's an important question, you can, you definitely go ahead. And it need not be only in the chat box. You can go ahead and ask your questions, maybe a couple of questions. And then I think we'll give a rest to sir's voice. So any Chodan, Varadarajan, Edwin, few of the names that I know. I think, sir, today we have got PGs from many institutions, sir, from Salem, from Coimbatore, from few from Pondicherry. I think from other DNB institutions also have come in. Because I just sent the message, we could accommodate only 100. So maximum was around 55 to 60 today. So we don't want to crowd too much so that we can, we'll lose, we could not accommodate them. So I think we leave it to other institution people also. Suppose just introduce yourself. And if you have any important questions to ask, I think you can go ahead.
Sir, it will be better if you move the cursor in the top of your screen and identify this as stop screen. Stop.
Yes, sir, you can stop share screening, sir. You can stop sharing. Stop sharing. Yes,
yeah.
Stop screening.
Sorry.
Yes, sir. Yes, sir. That's better, sir.
Thanks for telling me this. See, you can learn. Learning is one good thing about learning. You can learn till you're done.
Sir, and one more thing I want to say is, I think, this examination of spine, you made it very simple, sir. And, today, definitely, postgraduates will know that it is not very difficult to examine spine. If you are methodical, go step by step. I think it is very easy. So what Ramprasad said, it is very easy to understand spine, sir. It is, it's more like max. In fact, it is more than what it is in hip. Hip also, I used to say that it is like mathematics. But spine, it is pure mathematics. So you know your level, you know what is the root. You know what is the muscle involved, you know what is the level involved. And if you know the reflexes, obviously, whatever the reflex level. So it is only going to be a mathematics. You just keep, just like how you practice max, I think you can keep learning again and again. Sir, and you suggest only Hope and Field, sir, or you suggest any book that the postgraduates have to buy?
I just put Hope and Field just like that. There is no real reason for putting that. In the sense that it's a book I have with me. So I like the book. So that's why I put it. But any book.
No, because I am also a huge fan of Open Field, sir. Because I'm a huge fan of Open Field, because I always feel like reading an Hindu paper or something like that. So
I have read it so many times, Dhuru. I still like I don't know. I don't want to explain that. I cannot explain that. I like the book. Yes, but I'm happy you also like it. But it was only just like.
Yes, sir. So what about the PGs and anybody else who have any doubts? So make it fast. So just introduce yourself and then you can go and ask your question.
Hello, Edwin. I do not